Hello and good evening, everyone. Welcome once again to another session of the Renal Rounds. And today we are going to talk about a somewhat unusual topic, something that doesn't get discussed every so often in the nephrology meetings, nephrology conferences, etc. And that is about conservative care. So what is conservative care? Let's look at this pathway in the life course of a patient with chronic kidney disease. So these patients start by having chronic kidney disease risk factors. Over time, they want to develop chronic kidney disease, and chronic kidney disease in a certain proportion will progress to end-stage kidney failure. Now, we do know that not every patient of end-stage kidney failure gets treated. And normally we think that that is because either they do not come to medical attention or because they do not have the resources to be able to receive renal replacement therapy. But the default choice for us, for all patients with end-stage kidney failure, is to advise them to start either getting dialysis, hemodialysis, or peritoneal dialysis, or to undergo a transplantation. Patients either undergo transplantation directly, but most often there is often a period of dialysis, which may be perhaps the only option available to a large proportion of the patients. Patients switch between hemodialysis and peritoneal dialysis. But what we don't talk about is this box which is shown here, which is conservative care. Often this never enters the conversation that we have with our patients. And today we are going to really talk about this particular box and see what we need to know about this aspect of care of patients with kidney disease. So let me give you an interesting piece of information. In many Western countries, and there is definitely data available from Australia and Canada, which says that for every patient who starts dialysis, at least one patient who also will meet with an indication to start dialysis actually does not start dialysis. What does it mean? When they don't start dialysis, they opt to receive what is known as conservative care pathway. And the other situation is something that is illustrated by this particular case. So here is a case of a 76-year-old female with a long-standing diabetes, hypertension, who has been on dialysis for several years. This is a common story. I'm sure many of you have seen such cases. But where it gets interesting is the type of comorbidity that this patient has. She has had aortic aneurysm repair surgery and hysterectomy for endometrial cancer while being on dialysis. For the last 1 year, after having been dialysis for several years, she developed acute myocardial infarction. Her cardiologist placed 3 stents in her arteries, and subsequently she also had a cardioverter defibrillator placed. Her ejection fraction is between 10 to 20%. She develops intradiuretic hypertension. Her serum albumin has become low. She's anorexic. She's exhausted, weak, depressed. She often gets chest pain during dialysis, and she becomes breathless while walking room to room. She goes to her cardiologist. The cardiologist always prescribes something, and the family is really very devoted, and the family is committed to not letting her go, despite the fact that her functional status has become very, very low, and clearly she is not enjoying living on dialysis. So what this illustrates is something which has been now documented in publications, that kidney patients are complex. So in this paper, which was published in JAMA last year, Dr. Marcello Tonelli, using data from Canada, showed that patients who come to see a nephrologist, which means patients with kidney disease, have the largest number of comorbidities compared to patients who go to any other specialist, which is shown in the diagram on the left-hand side. And on the right-hand side, the figure shows that, again, patients who come to see a nephrologist actually receive the largest number of prescribed medications, once again, compared to patients who see any other medical specialist. So this is something which we knew instinctively, but this has now been documented using systematic methodology. So typically, hemodialysis patients have at least 9 symptoms. More than half of the patients on hemodialysis consistently complain of pain. We do know, it doesn't come as a surprise to anyone, that patients on hemodialysis have impaired health-related quality of life. Many patients on dialysis are usually depressed and depressed for a long period of time. We also perhaps don't know so well, at least not as well as when you see it put in a graphical format like this, that the prognosis of patient on long-term dialysis is worse than the prognosis of patients of many types of cancer, which is shown on the bars above the bar which is shown in the dark black color, which is survival for long-term dialysis. And you can see that survival of many types of cancer is actually better than those of dialysis patients. Now, this is worth thinking about, because if and when a diagnosis of cancer is made anywhere, instinctively death enters the mind of everyone who is dealing with such a patient. Whereas when a patient develops advanced kidney failure, we often don't think of death as a consequence which is staring this patient in his or her face, but we think that we will be able to give a reasonable, long period of meaningful life by putting this patient on dialysis. And that sort of misperception of the kind of prognosis such patients have is something that colors our decision, and we'll talk a little bit more about that later on. We also know that end-stage kidney failure treatment is expensive. There is data that shows that about 188 million people in low and middle income countries experience catastrophic healthcare expenditure as a result of kidney disease. And just like the number of comorbidities, the out-of-pocket expenditure due to kidney disease is also greater than that of any other disease group. In high-income countries, a large proportion of healthcare budget is spent on treating patients with end-stage kidney disease, even though they don't constitute such large proportion of the number of individuals who actually consume this healthcare budget. Now, let me show you this graph, which was published a few years ago in this publication in Clinical Journal of American Society of Nephrology, of the trajectories of various kind of illnesses. So on top, you see the trajectory of a kind of illness which is typified by colon cancer, in which individual who has this problem starts with a relatively high functional status that is shown here in the top line. And while the disease is being treated, the patient usually maintains a relatively high functional status until late in the course of the disease, when it becomes certainly perhaps metastatic, and the patient rapidly goes downhill and dies. On the other hand, in the bottom line, you see another kind of illness, which is characterized by old age, frailty, and dementia, in which the functional ability of such an individual is low even in the beginning of this illness, and it slowly goes downhill. There are minor troughs and peaks, and eventually over a period of time, again, death ensues. In the middle, you see the trajectory of a chronic illness, which is the kind of illness that end-stage kidney failure patients have. So they have, at the time they start on dialysis, for example, they have a functional ability somewhere in the middle of a patient with colon cancer and one with dementia, and they slowly progress downhill, but they have deep troughs because of intercurrent illnesses, which they experience either because of the basic disease condition or because of the treatment, such as dialysis. And often they come out of this illness, acute illness, but when they come out, they're never at the same level that they were when they actually had this illness. And again, they continue to go downhill and eventually they die. But Dr. Fliss-Mota thinks that if you don't put such patients on dialysis, then as shown in the red line, these patients will perhaps continue to have reasonably good functional ability without experiencing the kind of troughs that come with the complications related to treatment. And eventually they will perhaps follow a course parallel to that described for the colon cancer patient, in that eventually, obviously, they will deteriorate and die. And this is the kind of course she thinks that perhaps conservative care can offer these individuals. Also important to mention to you here is that patients who withdraw from dialysis, at least in the Western countries, do so for two main reasons now. One is because of chronic fatigue or failure to thrive, or secondly, after acute medical complications of the type that are shown in this slide, which shows you the troughs, which is in one of these troughs, the patient may decide that he or she is no longer willing to continue receiving dialysis. Now, let's talk a little bit about how we as nephrologists think about these conditions. Watching patients deteriorate and die is an inevitable part of our work. But we have been trained as sort of curative physicians, and we don't want to deal with death as an inevitable consequence of illnesses. We still think that death is a kind of failure, and that we shouldn't give up trying to save the patient for as long as possible. And this is often fed to us by the feedback we receive from our patients, who kind of compare doctors with God, which even increases the pressure on the doctor to really even play God. In many situations, we don't have a very good handle on being able to judge the prognosis of a given patient, and we are hesitant in admitting this kind of uncertainty, because we think that the patients may not necessarily think very well of us. We don't often know when is the right time to say enough is enough. For example, telling the patient that there is no point in trying to fight the illness anymore, in that it has run its course, and it's best to perhaps just let it take its course, and eventually let the patient go. Because we think that when we have this kind of discussion with the patient, they will perhaps misunderstand our intentions, and they will think of it as the doctors not having enough compassion for the patient or their families. So here enters, with this background, this concept of palliative care. So what is palliative care? According to the World Health Organization, palliative care is an approach that improves the quality of life of patients, and here it is important, their families. This is not something which we often think about. We think our primary responsibility is to the patients, but in palliative care, we also need to think about their families, because they are also facing the problem associated with the life-threatening illness that their loved one has. And how do we do that? We do that through preventing and relieving suffering by means of early identification and impeccable assessment and treatment of pain and other physical, psychosocial, and spiritual problems that may be associated with that particular illness. Why should we really, as nephrologists, think about palliative or supportive care? It has been now shown for many chronic illnesses that palliative or supportive care improves outcomes by proactively addressing burden of people with advanced diseases, including kidney disease. It's important to mention here that accepting palliative care does not compel patients to decline treatment such as dialysis, and the patient always has the freedom to come back and actually ask for dialysis if and when he or she so chooses. We also need to know that good quality palliative care delivery requires all the kidney care professionals, which include doctors, which include nurses, and in some instances even technicians, to have some basic palliative care skills, and we'll talk about what those skills should be. It's important to orient you to the evolving model of palliative care. So traditionally we have thought that when we see a patient with a chronic disease, we continue to be very, very vigorous in giving this patient active treatment, which is a kind of curative treatment, and at some time active treatment abruptly ceases and the patient enters a phase of palliative care, and of course at the end of the palliative care comes death. This model is now evolving, and it looks like this now, is that even when we are treating a patient with the intent of either curing or at least prolonging life, which is what we do when we put a patient on dialysis, right from the beginning, we keep the palliative or comfort intent also in mind. The component of the palliative or comfort intent is really small in the beginning, where we are focused on providing either curative or life prolonging intent. But as time goes by, and as the patient sort of enters the trajectory of illness that we discussed earlier, the component of palliative and comfort care slowly grows, and our focus on curative or life prolonging intent treatment slowly comes down. And after at some time, palliative care becomes the major part of treatment, eventually leading to death, but also now enters this phase of bereavement, which is also important for not obviously for the patient, because the patient is gone, but for the loved ones of the patient and the family of the patient who must deal with the loss of this individual. And it's important that the healthcare system supports the patients, their families, and everyone who's taking care of them through this entire process. There are a number of dilemmas that we face as physicians in determining the end-of-life care for dialysis patients, and they can be broadly classified into these two groups. One is the limitation of withdrawal practices. As physicians, we often tend to over-dialyze our patients because we are sort of geared, or our mindset is towards providing dialysis. And often this may be because of a number of reasons, because of our own personal beliefs and choices, or because of limited understanding by patients of the ability of dialysis to relieve their condition, and they may still continue to demand patients or their family members that the doctors continue to provide dialysis. We also face a number of knowledge barriers which prevent us from providing better end-of-life care. And as I said before, we often are not able to make a realistic judgment of the prognosis. We often don't know what could be the role of perhaps other colleagues. We as physicians are used to being in charge, and we often don't talk to our other colleagues like nurses or social workers on what their assessment is about the prognosis of such an individual. And this kind of lack of conversation is related to our sense of responsibilities, and many times there is a role conflict in our culture. Doctors, the boss, and others really don't often want to contradict his or her opinion. So, having said all of this, I hope you are convinced that palliative care is useful sometimes. So how do we actually identify patients for whom we should start considering palliative care? So the first thing that has been described is what is called a surprise question. What is the surprise question? This question is that if you ask yourself, would you be surprised if the patient who is in front of you died in the next 1 year? If the answer is no, you would not be surprised if this patient died in the next 1 year, then perhaps it is time to at least start thinking about discussing palliative care with this individual. There could be other situations in which we may make a judgment of poor prognosis based on patient-specific estimate of prognosis. There are some, not every patient who comes to you for starting dialysis is the same. And as I said before, in many countries, people with similar levels of kidney function do not necessarily start dialysis. So there may be some patient-specific estimate of prognosis which may indicate poor prognosis for a given individual. If a patient has been on dialysis, like the case that I described to you in the beginning, if the patient starts requiring hospitalization more frequently, if the patient doesn't thrive so well as he or she used to before and suffers from a loss of functional ability, then perhaps it is time for us to consider palliative care. If a non-renal terminal illness is diagnosed, which may limit the life expectancy of that individual, or may have a major impact on the functional ability, like a terminal cancer, that could be another trigger. Or in some situations, the patients may just lose personal drive to continue on dialysis, or may suffer from severe depression, in which case it may be appropriate to discuss palliative care for such individuals. Now let's come to the surprise question, and there is evidence now which says that the surprise question actually has a very good discriminating ability to predict patients who actually would survive in the next 1 year or so. As you see in the graph on the left, if the answer to the question that no, you wouldn't be surprised if the patient would die in the next 1 year, actually predicted that more patients for whom the answer was no died at the end of the next 1 year compared to those for whom the answer was yes. And this discriminating ability was actually better than a more complex comorbidity score, as has been shown on the figure in the right panel. Now, please do note that not everyone for whom the answer to the surprise question was no actually died. Just about 70% of patients for whom the answer to the surprise question was no was died over the next 1 year follow-up. So this is not a binary absolute predictor, but it actually gives you the ability to start such a conversation. So once you have started this conversation, what if the patient wants to ask you, what will palliative care do for me? So the first thing from the patient point of view is to provide symptom control. Also, from the patient and the patient families, they will enter a period of grief. There will be some sort of existential distress, and there will be some sort of conflict from time to time, both in the minds of the patients and in their families. Did I make the right decision? And the conflict, that conflict resolution also becomes part of providing palliative care. So how do we begin to provide palliative care to kidney patients? So there are three components to this. The first one is to initiate patient-centered communication. What is patient-centered communication? This consists of active listening. Active listening means that when a patient, we need to encourage the patient to say his or her piece, and we need to provide them cues so that they feel encouraged in sharing whatever they think with us. We should respond to their emotions, and we should gain their perspective to the best of our ability as to what exactly is the goal of the patient from receiving renal replacement therapy. For example, a patient might want to simply stay on dialysis for the next 6 months or 1 year to see his daughter or his son get married, or another person might want to really have a very, very long and productive life. And so their goals for being on dialysis would be really very different. And when we do that, we need to provide them with prognostic information, and providing this prognostic information should not be our own subjective assessment, but then there are validated tools which are available for this, and we should make use of those validated tools as much as possible. And while we are doing that, we must elicit patient values also. At the same time, we should start with providing basic symptom management, and these symptoms are both physical as well as psychological. And how will we do that as nephrologists? What we need to do really is to create a diverse stakeholder group. For this, we need to, first of all, map our local needs and our resources in our practice. Who are the other colleagues who are available? There could be nurses, there could be social workers, psychologists, spiritual care providers, there could be community leaders and dietitians, etc. Once you have identified who are the people who are with you, then based on this, you can define your vision for the palliative care setup that you want to develop in your center. Now, here is a tip. we do know that cancer community has long tradition of providing palliative care services. So we should try and develop a partnership with such services and hospices if there are if any such hospices are available. And as we'll see that in India, unfortunately, there are not too many hospices. Once we have done that, we should also develop an evaluation plan which will allow us to judge after a certain period of time where we are and do we need to grow and do we need to innovate. Now, let's come to the actual brass tacks as to what we will do. Once a patient has been identified as a candidate for receiving palliative care or supportive care, we need to assess them. And like for any other condition, we should always rule out any reversible factors which is responsible for giving rise to increase in symptom of the patients. Now, the general principle of providing palliative care is that we must start with a non-pharmacological intervention, but we should also recognize that some of these non-pharmacological interventions are not always realistic. For example, exercise. While in the beginning, when the patient has a reasonable functional status, he or she may be able to do an exercise, but once they become bedbound, obviously exercise no longer remains an option. And we will need to use drugs. But remember, the aim here is to ameliorate symptoms that impair quality of life. So quality of life becomes supreme here. And also we need to remember that patients often underreport symptoms. So to elicit the severity of symptoms, as I said before, there are validated tools available and we should use them as much as possible. There are a number of general principles that we need to be mindful of, and this is something which doesn't come naturally to us because we are often focused on managing progression and metabolic complications in patients with kidney disease. But once a patient enters palliative intent care, then we can relax a number of things in such individuals. For example, the BP targets don't need to be so strict. We can discontinue certain drugs which because we are not focused on really prolonging the life of the patient, but providing them with good quality. And one of the ways where we can provide good quality is by reducing the pill burden. So we reduce drugs which are not essential, like statins, uric acid lowering drugs, etc. Similarly, phosphate binders constitute a large proportion of pill burden, and we can actually discontinue phosphate binding agents also. But we must prioritize nutrition and quality of life, because if we continue to restrict phosphorus containing diet, then we restrict their protein, and once the protein restriction comes into play, then nutrition suffers. We should use diuretics to the extent possible for volume control, and we should continue to maintain sodium restriction. Anemia, of course, is an important cause of reduced quality of life, so we should continue to use iron and erythropoiesis stimulating agents like erythropoietin or darbepoetin and so on. These patients will become acidotic, and we should use soda bicarbonate whenever it's needed. Hyperkalemia should be watched for, and dietary restrictions should be appropriately instituted. New drugs we know, like patiromer and zirconium, are now approved for use in management of hyperkalemia, but they're not available in India. But once they become available, they can be used to manage hyperkalemia in these individuals. The important point to be made here is that we should not focus on biochemistry, but on the symptoms and the quality of life. So in terms of specific symptoms, I will now talk about a few main symptoms that your patients will often complain about. The first one is restless leg syndrome, and management of that, again, starting with the general principle of non-pharmacological treatment, is to avoid stimulants like coffee, etc., and ask the patient to engage in mental alerting activities. For those who can, encouraging them to do crosswords or play Sudoku or read newspapers or even watching television, and doing physical exercise helps in management of restless leg syndrome. Iron deficiency and anemia has been associated with increased symptomatology, and we should correct those. And if the patient still requires medical treatment, then the drugs that can be used here are gabapentin, pregabalin, or dopamine agonists. Dry skin and itching is a common symptom, and for that we should start by telling our patients to take proper care of the skin, use maybe coconut oil application, other kind of moisturizers, stay in a cool environment to the extent possible, and we should ask them to clip their nails, ask their family members, because they can often scratch themselves and draw blood, and if you keep the nails clipped, then the injury will be much less severe. In terms of therapeutic agents, we can use topical agents like capsaicin, menthol, and camphor. And if oral drugs need to be used, again, we go to the gabapentin, pregabalin, tricyclic antidepressants, etc. Now, other symptoms would also require control, and I would not talk about all of those, but will draw your attention to this paper by Dr. Sarah Davison, which appeared in C. Johnson just about a month ago. And the principles here are that for management of nausea, vomiting, we should ask our patients to take small, frequent meals rather than large meals. And in terms of the drugs, we can use ondansetron, metoclopramide, or if required, we should use olanzapine, which has a relatively low risk of extrapyramidal syndrome. Patients in end-stage kidney failure can be of two types. Pain in end-stage kidney failure patients can be of two types: neuropathic pain or nociceptive pain. We should distinguish between the two, and there are algorithms which are given again in this paper, and you should use them. And algorithms are also available for breathlessness, respiratory secretions, nausea, vomiting, agitation, restlessness, and how should we manage these symptoms. I would encourage you to go to this paper and look up the specific algorithms. Now, drowsiness often causes a lot of anxiety and a lot of distress in the family, but often drowsiness might be preferred in this situation because we know that the patient is not in pain if the patient is drowsy, and of course they should receive nursing care as needed. Now let's come to the palliative care situation in India. In India, unfortunately, we don't have any national policy about palliative care. There are a large number of organizations in now several states and union territories, but they're often concentrated in large cities and are associated with cancer centers. The large exception is Kerala, which has a number of institutions and societies. Delhi also has some organizations. There is a major limitation in drug availability, which is required for appropriate palliative care provision, especially for pain management. In terms of research in palliative care, you have an Indian Association of Palliative Care, and there is also a journal. Now, worldwide, there is this organization called Worldwide Palliative Care Alliance, which classifies countries into different levels depending on the level of care that is available, starting from level 1, where there is no hospice or palliative care activity, to level 2, capacity building activity, to number 3A, where in countries where isolated palliative care is available, and you can go down the list as is shown on this particular slide. India, until recently, was listed at level 2, but it has recently been moved to 3A, which means that the Worldwide Palliative Care Alliance recognizes the presence of isolated palliative care facilities in India. Now, in terms of legal provision, the Indian Law Commission came out with this document on medical treatment on terminally ill patients for protection of patients and medical practitioners. And it talked about adult patients' rights to self-determination and right to refuse treatment. And they said that this would be binding on doctors if the patient made on the basis of informed choice. This is really very important, and this goes to the concept of shared decision making, in the sense that any treatment decision should be made in a shared way by the doctor and the physician, which is extremely important in the situation that we are talking about. And this document also says that the state's interest in protecting life is not absolute, and that if a patient refuses to accept active medical treatment, it does not amount to committing suicide, which was something which was considered earlier. And similarly, if the physician endorses the patient's wishes not to continue active treatment such as dialysis, it does not constitute abatement to suicide. And that if a patient does not wish to receive active treatment, and if the doctor still forces them to undergo invasive therapy, then it might even be considered unlawful battery. It's important to point out the 2016 Aruna Shanbhag case. Aruna Shanbhag was a nurse who lay in a vegetative state for several years, and eventually there was a case in the court which was decided in favor of allowing a withdrawal of active care from Aruna Shanbhag, allowing her to die, and this led to this bill, which is currently in the draft stage, called Medical Treatment for Terminally Ill Patients Bill. So in the end, in conclusion, conservative or supportive of palliative care is an integral part of care of patients with end-stage kidney disease, and it should be part of the discussion in the continuum of care. Kidney care professionals need to develop palliative care skills. It improves our ability to provide patient-centered care to those those patients with kidney disease who we take care of on a daily basis. Kidney palliative care will also rationalize the cost of care, really, because providing dialysis is expensive, and often in many setups, many patients continue to receive dialysis who should not, because the quality of life does not improve. They do not contribute anything to the society and to their families, and really they often suffer on dialysis. If it done appropriately, it also provides comfort to both patients and their families. I would like to say that we should know when it is time to start this conversation, and that enough is enough, and we should do it in a very empathetic manner, so that the patients and their families do not consider it as if we are sort of abdicating our responsibilities and abandoning these from the healthcare system. And provision of palliative care really tells them that we don't abandon them, but we continue to provide active care. Only the difference being that the kind of care that they will receive has changed now. But to do that, we need to build capacity, we need to map our resources, we need to also perhaps generate new resources. We need to make sure that the medications and the structural framework which is required to provide such a care becomes available. Right now, it is limiting in India, but over a period of time, hopefully that will improve, and we'll be in a situation where we are able to provide appropriate supportive care to our patients. Thank you very much for your attention.